Welcome to Balls Deep, a humorous yet informative medical show with a mission of optimizing your performance in the bedroom, the bathroom, and the boardroom. I'm your host, Dr. Joe Pazona, a board-certified urologist and CEO of Pazona MD. We hope you enjoy. Now, let's jump right in. Hey, Stream Team, Dr. Joe Pazona here with another episode of Balls Deep. This week, we're going to do something a little bit different. No, Catherine has not been fired, but we thought it would be great to bring in people much smarter than me so you guys can do some deeper dives and learn from some of the experts we have at Pazona MD, as well as some of my colleagues throughout the country. So today, I have the distinct pleasure of welcoming Miss Brooke Faught. She went to undergrad at Ohio State. We're not going to hold that against her.
Go Buckeyes.
She did her grad school at UPenn and then did her doctorate of nursing practice at Vanderbilt. So clearly she is undertrained and doesn't know anything she's talking about. In 2005, Brooke started the Women's Institute for Sexual Health. And after many successful years of practice, I eventually was able to recruit her over to Pazona MD, where she's now the Director of Women's Health at the Southern Sexual Health Institute. So, Brooke, welcome to our show.
Thank you so much for having me. It's lovely to be here
Yeah.
and to replace your beautiful wife.
Well,
my goal is to do that permanently, just so you know. I'm just kidding. I'm totally kidding.
I'm a handful. So she'd be like, you know what, you could take them some of the time, so it's okay. No, I couldn't think of a better first guest. And don't worry, Kat will be back. But want to kind of give this a try and couldn't think of a better person. There's so much controversy, I think, about women and today's topic, menopause. So I thought we would just kind of deep dive right into that, if that works for you.
Yes, very, very important topic that is underrepresented and not openly discussed, unfortunately, in our culture. So yes, happy to be here.
Awesome. Well, at this point, we will go ahead and dive right into our episode.
Balls Deep.
So, Brooke, we've previously done an episode on menopause, and I want to make sure that I'm always speaking correctly to the audience, even though this is not something I have expertise in. But really, my understanding is menopause is really a diagnosis you can only make after the fact, right? In that it's the period of which a woman has not had a menstrual cycle for 1 year. But we know as healthcare professionals taking care of women that there's this roller coaster of all the years prior we call perimenopause that doesn't really get attention. So help us better understand that sort of tumultuous time period in a woman's life of perimenopause and when can it start and what do those symptoms look like and why it's not just important to kind of look at, I haven't had my period for a year, now I can go get help.
Yeah, no, it's a really good place to start for sure, because a lot of people are really confused about what is menopause, what's perimenopause, premenopause, postmenopause. Menopause really, like you alluded to, is a one-day event. It's the anniversary of the last menstrual period. Some women don't have a uterus, so if they're not menstruating, how do you diagnose that, right? And so if a woman has had a hysterectomy with both ovaries removed, so it's really more so about the ovaries being removed, or a oophorectomy, and if both ovaries, not just one, but both have been removed, that is surgical menopause. And as of that moment of those ovaries being removed, that is menopause, the beginning of menopause for that individual, regardless of where they are in that trajectory naturally. There's also chemically induced menopause, where certain medications, like for instance, women going through breast cancer treatments, some of the medications or therapies can impact ovarian function, and that will lead to a disruption of the communication between the brain and the ovaries, which leads to an altered onset of menopause. In some cases, if we don't know where the woman lies in that menopausal journey, we will get blood work that can help identify if they are officially menopausal or close to it. And that's another big question. A lot of women say, can I get my hormones checked? And looking at estrogen and progesterone in that time frame, as you mentioned, that tumultuous kind of roller coaster, looking at estrogen and progesterone and some of the more common hormones that we think of with regard to women, it fluctuates so radically. So doing this massive hormone panel is not always necessary. I just like to check. Oftentimes, it's as simple as FSH, or follicle stimulating hormone, and that will help identify if it's significantly above, usually 20 or so. That indicates that a woman is entering into that phase. Now, that perimenopausal nightmare that most women feel their worst, I call it PMS on steroids, because it really is. You lose that kind of consistent ovulation, or there's a disruption in consistent ovulation that leads to more erratic fluctuations of specifically estrogen and progesterone that lead us to feel really crappy in many cases. Some women are lucky and they just sail right through menopause. I tell those women to not mention that outside of the room because they're probably going to get beat up by other perimenopausal women. But more often than not, women will experience one or some symptoms or array of some symptoms. And it's not so much when we spike up with those levels as we're having those really big peaks, but more so as we withdraw from it. Our body doesn't like to withdraw from anything, and that includes hormones. So just like with PMS, when we're withdrawing from that estrogen and progesterone complex, oftentimes that the feelings and the symptoms that occur are really quite miserable, and it's more of a profound effect of that during perimenopause. And so that's why women think that they're going insane, because they kind of are due to a hormonal disruption.
Yeah, and I bet you talk to their partners and they're going to be like, "Oh yeah, this is rough."
Oh yeah. I have lots of tears when I just validate and say, "You aren't going crazy. This is a medical, expected phenomenon, and you don't have to feel like this. We can work on it."
I think you brought up some excellent points. I think first and foremost, I don't think we do a great job as healthcare professionals in this surgical and medical induced menopause that you alluded to earlier, right? Like we just go, "Oh, we're just going to take all your stuff out." And woman goes, "All right, well, I don't need it."
Yeah.
Not understanding that there's huge implications on that woman's quality of life from that moment. And we all have taken care of women who in their early 30s have had total hysterectomies and their ovaries removed. And I don't think we do a great job of preparing that woman for what she's going into or discuss some of the side effects of some of these medicines that can induce this menopause. So I think it's an important point. Most people think incorrectly, like, "Oh, I don't have to worry about this till I'm in my 60s. But yet we induce it immediately in some women much younger. And then you talked about this, what a great word, erratic, that period of perimenopause. And we can even go back. Some women have erratic hormones their entire life, right? I mean, women's hormones are fluctuating throughout their menstrual cycle. And we know some women who are just kind of cool as a cucumber and even, and others who really struggle. So talk more, to the women about hormones, because I think that word gets thrown around a lot, and, but we're talking about lots of different substances and things that have been sent out in our body in different levels in a woman's life and varying from day to day, from week to week, right?
Yeah. That's always a big question of women of all ages. I want to get my hormones checked, or tell me about my hormones, or how do I know if my hormones are where they should be? And generally speaking, if a woman is menstruating, if menstruation is consistent, even if it's slightly irregular, but it's occurring, more than likely your quote hormones or estrogen, progesterone are generally where they should be. We more so go based on ovulation, and ovulation will induce a menstrual cycle at some point. And then as we get closer to menopause, that ovulation or that regulator will begin to shift or change to some degree. Sometimes that's experienced as complete stopping of periods. Sometimes it's infrequent or lighter periods. And sometimes it's the unfortunate long, heavy, consistent cycles. And those are the ones that are quite bothersome, as you can imagine. Lots of good points there. One of the things I want to touch on that you mentioned, so we, especially in the United States, we do not prepare women properly when it comes to what to expect after surgical menopause. We know what is going to happen if, especially a younger woman, has her ovaries removed. We know that there's going to be an immediate menopause. So you don't even get that transition period. It's just welcome to the party, And when we think about it, it's similar to some of the other surgeries that men go through. For instance, prostate surgeries. Certain men go through chemical castration, or, in some rare cases, if you have a testicle removed. Men are oftentimes very much prepared as to what to expect. Let me preface, I'm not referring to having your testicle removed for prostate cancer, so I don't speak to the men.
I'm going to quiz you on the balls after this here, Brooke.
I am on the Balls Deep podcast, but...
I know it's been a bit since you've played with those, but at least professionally.
No comment. Go Buckeyes. Yeah. Okay. So, but we know so much about what to expect with men, and men are oftentimes prepared really well as to, hey, you might have some erectile dysfunction. These are things to prepare and expect, and we don't do the same for women. We don't prepare them. It's more just like, hey, you've got this issue. Let's just take everything out and good luck, goodbye. So that's where I come in.
Yeah, I mean, you bring up an excellent point. And even as a man, I recognize the biases that exist in healthcare. There's not a single man in this country who goes into a prostate surgery not knowing that there's a good chance he's not going to be able to get it up in the bedroom anymore, right?
Oh, yeah.
We look at all the low T centers that are out there that are going after men going, oh, no, your levels are dropped. Like, those guys are still making testosterone. I mean, we're talking about women 100% chance, if you live long enough, your hormones are going to go to zero.
Or close to it.
And we don't prepare women for that. We blow it off and go, oh, don't worry about this. Grandma dealt with it. Mom dealt with it. You'll be fine. And so I love that you're changing that narrative there.
Yeah, I think women are used to experiencing hormonal fluctuations and changes associated with menstrual cycles and so forth. But so we put up with a lot, and it's like the incontinence conversation. So women leak urine, women have sleep issues, women have hormonal fluctuations or menstrual irregularities or sexual complaints. And it's just kind of considered this quality of life thing that's not super important. And it's brushed under the rug because we're real good at just kind of trekking along and keeping moving and taking care of others. But when it starts to impact our overall, not just personal quality of life, but our ability to function in the workplace and in our relationships and just all this collateral impact, that's where it can be really, really problematic. And I think we don't appreciate that as much in our culture.
I want to come back to this point of the dangers of the stoic woman, the silent woman. But I think before we do that, why don't we, for the listeners, kind of walk through a sort of the laundry list of potential symptoms a woman might go through either perimenopausal or menopause. So she has a better idea of understanding like what she's feeling are probably related to her hormones. Because we often see outside of your area of expertise, women coming in with complaints that are not being addressed or being incorrectly attributed to other things going on.
Yeah.
And we're like, this is your hormones. Like, let's just fix your hormones. A lot of this gets better. So from your experience, what are women coming to you complaining of, and what are women not recognizing really are symptoms of menopause? And then you get them on therapy and they go, oh my God, like who knew this was going to get better?
Yeah. So the symptoms of menopause, this is not rocket science, right? We know why it happens and we know what the treatment options are. And it's very simplistic, and it's amazing how just a simple therapy can make such a huge difference in a woman's life. But the symptom profile for women experiencing menopause can vary from absolutely nothing, which is rare, to the most common symptoms we hear about: hot flashes and night sweats. They tend to occur pretty early on as hormonal changes begin to occur. We also hear about it a lot in the media because most of the therapies are indicated for that purpose, and it's considered a more socially acceptable symptom to discuss openly, both in public, with friends, with family, with your healthcare provider. We never want to embarrass our healthcare provider, right? A lot of patients say that, both to me as well as in surveys and studies. Women are they think that they're just going to humiliate their healthcare provider by asking about more risque topics like sexuality and vaginal health, bladder health, bowel health. But that really isn't the case. You should not be uncomfortable discussing that. And if you find that your healthcare provider shies away or turns red or starts stumbling, you need to find another healthcare provider probably, or maybe give them a second chance because maybe it was a bad day. But some other symptoms associated with menopause include vaginal dryness, pain with sex, other sexual health concerns, low libido, changes in arousal and orgasm definitely can be associated with menopause. We also see things associated with the bladder, so leakage of urine or frequency, urgency. We oftentimes don't really associate that with menopause or hormone-related changes, but when we think about how estrogen promotes cellular regeneration in many parts of the body, that includes the bladder and the urethra. And so if a tissue or or an organ is not supplied with, the ingredients that it needs to ripen those cells, which is a little bit of a weird way of saying that, but that organ or that structure may not function as efficiently as it used to. So we start to see problems associated with that. Speaking along that line, changes to skin, hair, nails. Women come in, they're like, I'm so crepey. I feel like my face has changed. My hair isn't growing the same way. My hair's thinning. And then joint pain is a big one. Estrogen's a very lubricating hormone throughout the body. And so another big symptom that oftentimes women don't recognize as associated with menopause is joint pain all over. Sometimes it's more localized, but oftentimes it's everywhere. So you wake up and you feel like you're creaky like the Tin Man from Wizard of Oz. And then insomnia, sleep issues. And that, I think, is another huge topic that needs to be better addressed. Because if you are not sleeping well for any reason, you are not getting that restorative recovery phase of your life that you need every single day. And that in and of itself will send you into a spiral. I think any human can admit that. What am I forgetting? I'm sure there are other symptoms that are on that list I probably should address, but those are probably the most common.
I think you hit a lot of pain points for women. Needless, I mean, you hit, pretty much all the important parts. And I think one of the more striking parts was sort of the cosmetic part of it, right? I mean, really from the top of your head to the tip of your toes, your nail health, your hair, your skin, and then no one looks good after only a couple hours of sleep, right?
Yeah.
And so we've talked on this podcast about how sleep is one of the pillars of wellness and how essential that is. And so, I mean, really hearing a lot and really the entire experience in the bedroom. I mean, you said from libido to lubrication. So it's not surprising that I often hear on the male side of things, when I go, hey, it looks like you're struggling with erections. Doc, don't worry about it. My wife just doesn't enjoy it anymore.
Yeah.
And now I go, do you know this woman? She's going to help out your wife and you're going to have a new friend. Because you're right that women are not talking about this. And so then the guys are struggling as well on their side. And we're going to focus, of course, on the women. And so I love that you bring this up and we're starting this conversation, right? That women shouldn't be embarrassed about this. And it's pretty clear sex doesn't feel good because your hormones are not high enough. And that there are safe ways to bring it up, which we'll dive into later.
One of my colleagues from years ago had the best analogy. She goes, I love eating a Snickers bar, but if somebody punched me in the face every time I ate a Snickers bar, I'd probably stop enjoying eating that Snickers bar. And I thought, that's brilliant. Yeah. So even if libido and arousal and orgasm are intact, if it's uncomfortable or you're dry or it's burning, then you're probably not going to want to have sex, right? You're going to avoid it. And then when you combine all the other factors, you're not sleeping, you feel like you're losing your mind. So cognitive changes, I left that off the list too. You don't feel sexy. You feel like your body is changing despite all of your efforts. And everything else sexually is not functioning like it used to be. You feel betrayed by your own body. I hear that a lot. That will 100% lead to a sexual aversion, for sure.
I imagine you then see women who have gone through this and they must be pretty depressed. I mean, pretty down. I mean, this doesn't sound like a life that anyone goes, sign me up. So, I mean, you've got to see that once these women get treated, I mean, it must just be game changing.
I mean, I feel like I'm, God sometimes when they're like, oh my God, I gave you a prescription that has been around for decades and decades, but you think I'm this like magician. It's pretty cool to have that effect, but I wish that weren't the case. I really do. I wish that women had more knowledge and accessibility or ability to access these products, it both in cost and just knowledge, because it will profoundly change a woman's life. And this is what I tell women when they say, what did women do in the past? I just don't understand. And I tell them, we didn't live this long. So this is a new problem. We've never really had to think this through. But as we've put all of this incredible knowledge and science to elongating our lives, it's about time that we finally focus on that quality of life.
So we're really focusing on the quality, not the quantity, and that unfortunately we're doing a good job of keeping people around much longer, right?
Yes.
And so that quality comes into play a bit more. And then we're also just getting more comfortable with these conversations. I mean, I don't think there was a podcast 5-10 years ago talking openly about all the symptoms of menopause and that it's okay for women to want to, go get treatment for this.
Yeah. Or if there was, it probably got shut down because it was too risque.
Yeah. Well, why don't we kind of wrap up and let's say we've got a woman who's listening and let's talk to that stoic woman I was alluding to earlier who's like, I'm just going to suffer in silence. I've been dealing with this for years. I don't need to come in and see you. So talk a bit more about the impact you're seeing on that woman, whether it be from an overall physical health or a mental health, why that's a dangerous mindset to have, this idea of I'm just going to suffer in silence because this is, quote, not life-threatening. What are some of the real impacts that this woman may be underappreciating if she just sits there and decides not to get treatment?
Yeah, sure. And by no means am I saying that every single woman needs hormone replacement therapy. There's a lot of different therapies. Sometimes we target just the specific symptom or symptoms. Sometimes we go full-fledged into hormone replacement therapy, but that conversation needs to be had. You do not have to deal with this, okay? The symptoms you're experiencing, if they're bothersome enough, just like any other condition that you could possibly deal with in medicine, there are treatment options. And again, there are healthcare providers out there that are knowledgeable, that know how to kind of have that conversation with you and balance out those risks and benefits to make a decision about, number one, is hormone replacement an option for you based on timing and risk factors? Number two, is it something that you want to do? Number three, which option out of that pile of different hormone replacement options is best for you with your lifestyle and cost and so forth? But yeah, so it's some of the symptoms like hot flashes and night sweats, those will resolve over time. But a lot of these symptoms and also other signs like osteoporosis, bone health, sleep, other things oftentimes are chronic and progressive, including vaginal dryness too. And so if left untreated, they could progressively worsen to a point where it's not just pain with sex, or it's not just like I feel a little uncomfortable, but rather it hurts to wipe after urination. And that's just entirely unacceptable.
Yeah. And not only the quality of life, but you alluded to sort of the bone health. We've talked before about how, estrogen is essential to maintaining healthy bones, and that, having a hip fracture is a big deal as you get older. So we see all these people who, they maximize their life for making sure they don't get breast cancer. They maximize their life to make sure they don't get heart disease, but then they fall and have a hip fracture and they're dead within a year.
Right.
And so I think we underestimate the benefit of hormone replacement and the role estrogen plays in bone health. And I mean, it also seems, and correct me if I'm wrong, that there are a lot of these autoimmune conditions and other diseases, we learned about in medical school. And it's like, why does this always happen for women between ages 40 to 60? Like, it's not lost on me. I mean, I don't have the data to support that, but I don't know what you've seen in your practice.
Oh, yeah.
I mean, it seems like there's a lot of these illnesses. We go, what causes this? We go, well, hey guys, how about the fact that this woman's hormones just dropped in the tank?
Yeah.
And that maybe this is the immune system way of responding to that. Because we're really this, when we talk about hormones, it's not just one, it's a delicate balance of all these neurochemicals throughout our body. And
right.
as you alluded to, estrogen plays a role in almost every tissue in our body.
Yeah. All very valid, comments here for sure. And testosterone is another one that we need to discuss at some point. I think maybe we'll discuss that
at next episode.
Another episode for sure. But yeah, I mean, it's just, it plays a role, estrogen, progesterone, and a slew of other hormones. Like we didn't even get into the thyroid. For instance, if we just take one health condition, such as thyroid deficiency or even Hashimoto's, which is an autoimmune condition, oftentimes we'll see the onset of symptoms, not necessarily the onset of the condition, because it is more of an underlying autoimmune, but we'll see the presentation of symptoms that occur around menopause, or vulvar skin disorders, lichen sclerosis, things that tend to kind of where menopause precipitates the onset of those changes, those findings. And you're right, we absolutely don't recognize this correlation. It's like, come on, guys, let's use our brains here. We are smart humans. And yes, a lot of these things will pop up around that time frame. I like to think about the kind of I call it a symphony of hormones. What did you say? It's a, you used another term. I like that.
I don't remember anymore. I'm just mesmerized listening to you because I'm learning so much here.
We're like 37 seconds past that. But no, I call it a symphony of hormones. And during childbearing years, we have this beautiful kind of like parameter that we stay within. And then when we hit perimenopause, we have more erratic fluctuations. So that parameter shifts radically. And that's why we have such awful symptoms. But it's that beautiful symphony of staying within that normal, healthy parameter that keeps everything at equilibrium in many cases. You take that, you pull that rug out, and all hell breaks loose. And you see just this downward stream or domino type effect. I see it all the time. And I want to go back to one other thing you said. You were talking about osteoporosis and hip fractures. Guess what causes hip fractures? Running to the bathroom because you have to pee all the time, or because you're hurting and you need to go wipe or use the bathroom, or, all of these these conditions, again, that domino effect, they integrate, they tie in together. And that's where we run into menopause can lead to early death, okay, in many cases. And I'm not just talking about, driving your car off a bridge because you haven't slept in 6 years. I'm talking about estrogen deprivation over long periods of time, leading to thinning bones, leading to vaginal dryness, leading to bladder dysfunction, leading to running to the bathroom and slipping and falling and breaking your pelvis. And next thing you know, you're bedbound. And then you have long-term complications that can lead to increased morbidity and mortality. And so it's a big issue, and we need to better address this, is, I guess, the best way of summing that up.
And that scenario you just ran through so beautifully, it is not like some conspiracy theory or some 1 in a million chance. Mm-hmm. That can happen very easily. I mean, that sequence of events makes perfect sense, and we see this. And so I think there's a great place to conclude and we'll come back to this idea of the symphony of hormones. And if you'd be up for it, I'd love to do another episode here and do a deeper dive there. So
let's do it.
Awesome. Well, why don't we sum up today's episode with our second favorite segment, or Kat's favorite segment, called
Just the Tip.
Okay, so what did we learn today? So number one, you do not have to just deal with the symptoms of menopause. Brooke is amazing. I wish I could clone her and get her out there in every community, but come and see our team at Pazona MD. Brooke and our team can absolutely help you, and there's colleagues throughout the country who can. Number two, hormones are not all created equal. It's really important that when a woman goes in and goes, I want my hormones checked, that we're really discussing, well, what hormones are we addressing today? Mm-hmm. Because each one requires a different workup and evaluation. Mm-hmm. And number three, menopause impacts women differently. However, all women, let me say that again, all women will experience some degree of symptoms if they live long enough. And so being that stoic woman who suffers in silence, it's just not a card we should be playing anymore, should it?
Absolutely not. Speak up.
Love it.
Be your own patient advocate.
Yep. Well, Brooke, this is great. If you're up for it, let's come back and do a second episode.
Let's do it.
Love it.
So are you saying that I'm taking over Kat's position permanently?
I would not go there. I would not go there.
I will never replace the Kat.
No, absolutely not. Although honestly, she's like, God, I don't have to podcast. I mean, if you listen to most of the episodes, she's complaining about how I drag her here, but I think she's
fantastic.
So, Stream team, thank you for joining us today. Please leave some comments. If you like this format, we'd love to have more guests on the show. And if you have any favorite doctors or people in healthcare that you'd like us to interview, give us suggestions. We want this to be of value to you. So with that, please remember to show yourself a little more love and grace. We're all works in progress, and these are opportunities to grow. Thanks, and have an awesome day.
Thank you for listening to this week's episode of Balls Deep. If you'd like to join our stream team of listeners, please click the subscribe button on your favorite podcast platform. For more information about our practice, Pazona MD, please visit pazonamd.com. This podcast is for informational purposes only, and the content is not intended to be a substitute for professional medical advice. The show does not constitute the practice of medicine. No doctor-patient relationship is formed through this podcast or any of the social media channels related to this show. The use of this information is at the user's own risk. Users should not disregard or delay in obtaining medical advice from any medical condition they have, and they should seek the assistance of their healthcare professionals for any such conditions.